It is 5 o'clock. I'd like to welcome everybody to the Indian River County Hospital District meeting. Welcome to those also watching on TV. We'll get right into the agenda here. We'll start with the consent agenda. I need a motion for the approval of the special meeting minutes dated January 17th, the regular monthly meeting minutes dated January 18th, the special meeting minutes dated January 30th, and a February disbursement of, Mr. Jones? $1,789,645.98.
Before we do approve it, and there's a motion, I would just like to say that there's been a request from Mrs. Zudans to change the January 17th meetings to add the names of those that voted nay.
Yes, thank you.
All right. So I would like approval with that change that we know is coming.
So move.
Right here, second?
Second.
Second. All in favor?
Aye.
Aye.
Okay. I really don't have anything to report on today. We are still working on March 5th. We will be going on a trip down to Weston, and the Cleveland Clinic folks have confirmed that, and they will be there waiting for us. So
Okay.
That's good. District Council report, Jennifer.
Thank you, Madam Chair. I've continued to work quite a bit with districts, retained special transactional counsel this past month with regard to our hospital partnership process. Attended the most recent Partners Collaborative quarterly meeting, and also worked with the board chairwoman and our executive director to interview valuation firms, which was discussed in more detail yesterday as we move through this process. So another busy month, but quite a bit of what you've heard from me the past few months as well. Does anyone have any questions?
No, hearing none. Financial statement review. Mr. Jones?
The district remains in sound financial condition. Thus far, the district has received tax revenue, as your report indicates, totaling about $11.8 million, and expects to receive another $1.8 million during the fiscal year. At the end of January, the district's bank balance stands at about $12.9 million. If the program spending remains on budget, that is anticipated to require a little less than $8 million between now and fiscal year end. In addition, normal administrative expenses are budgeted to require just a little over $600,000 more between now and year end, and the partnership spending related to now the Cleveland Clinic process will require another $750,000 or so by year end. And of course, we're still spending money on the Human Services building. So once that gets completed, it's another $230,000. Even adding all this up, projections are for the district to expend about $9.8 million more between now and fiscal year end. So the bank balances will be plenty to cover this and still maintain our required reserves. So that concludes the Treasurer's report.
Any questions or comments? Okay, hearing none. Executive Director report, Anne Marie.
Okay, I guess just a couple of things to draw to your attention. I did include in your packet this month, along with my report, the board self-evaluation process, which is outlined in our strategic plan. So if you will all complete those forms and return them to me, I would appreciate that, and then I will tally those and do an analysis of that, and we'll talk about that next month at our chairman's meeting. One thing I did not put into my report that I am, I guess, remiss in reporting to you on is the proposal that was before the legislature this year for the CRC 69, which was the proposal to amend the Constitution to allow for the ballot every 10 years to reconfirm the taxing authority for special districts. And they did remove that from consideration and said that it would be better placed and considered in the state constitution, so I don't think that that's coming through this session. So next session, I imagine they will revisit it in the as an amendment to change for the state constitution as opposed to the federal constitution, I guess. Other than that, you can read my report, and if there were any other questions, I think we covered everything else yesterday at the chairman's meeting.
Okay. Any comments, questions? Okay.
Thank you.
Moving right along, hearing none. IRMC, I believe the auditor is going first.
Good afternoon. I'm Dan Vandenberg with the accounting firm of RSM. We're the auditors for the Indian River Memorial Hospital and its subsidiaries. And I have a presentation someplace. There it is.
Okay.
Northwest Medical Center.
Funny how that popped up. Thank you. It's fine. So we're here to present the summary of the audit services that were provided, conclusion to those services that were finished in January 2018. So we performed audits of Indian River Memorial Hospital and the subsidiaries, and that's a consolidated financial statement. So there are a number of subsidiaries that the hospital owns, including the foundation. They control the foundation. We did a separate audit on the foundation and issued that financial statement opinion to that board, to that audit committee. On both the foundation and the hospital, we issued unmodified auditor's reports, which is some people call a clean audit report. It's the highest level of reporting that the auditors can provide. And those are both dated January 25th, 2018. As part of our responsibility, we also met with audit committees for both of those organizations, and we went through a number of communications related to the audit that we're required to make to them. I'm just going to summarize those communications with you today. So, first of all, no significant unusual transactions occurred during the financial statements period of time. There were a few audit adjustments that were made as we went through the process. The most significant of those moved a land sale that was recorded in 2017. We moved that to 2018. It was recognized correctly, but it was recognized early rather than waiting until the transaction actually occurred. There were several other smaller entries, all of which netted to reduce net income by $918,000. Most of that $918,000 related to that land sale. It was about a $1.1 million land sale. So the sale was right, just in the wrong period of time. As auditors, we also accumulate what we call uncorrected adjustments. So these are adjustments that are minor in nature. We accumulate those to make sure that as those adjustments are accumulated, they don't add up to a material amount. The minor amounts added up to an aggregate of $298,000, which we and management consider to be immaterial to those financial statements, so those adjustments were not posted. There were no changes in accounting policies. Accounting policies can be changed by the industry, so generally accepted accounting principles, the FASB, Financial Accounting Standards Board, changes standards. There were no such changes during the year, and management might also elect between alternatives. There were no such changes during this period of time. The significant part of an audit of the financial statements, particularly of a healthcare entity, relates to estimates that management's required to make in those financial statements. In a healthcare organization, one of the largest estimates relates to accounts receivable. So what is the net value of those accounts receivable at any point in time is always a difficult task. So the hospital may bill $1 in charges, but the collection of those because of Medicare, Medicaid, or payer contracts means that we're probably only going to collect somewhere around 30 cents on the dollar. So the determination of what is the collectible receivables at a point in time is a significant estimate. We also have contracts with third-party payers, in particular Medicare, Medicaid, and then a number of other payers. We look at the provision and contractual settlements with them. Sometimes those contracts take years to final settle. We also have, the organization has self-insured for a certain level of medical malpractice and workers' compensation. So we're looking at those estimates and how management's determining what those liabilities are at the point in time of the financial statements, and then contributions at the foundation level to the collectability of those, and then a big one is the net pension liability. So we've got a defined benefit pension plan. Those pension plans have a number of estimates or assumptions that go into them that drive the net asset or liability that the hospital records. So we spend a lot of time looking at the inputs to those. We may use subject matter experts like actuaries to help us in our process. We made a conclusion that management's estimates are reasonable. By the way, we also look back to see how good they have done in the past and whether or not those estimates made a year ago turned out to be reasonably accurate, and we found that they were. So management has been making reasonable estimates in the past. We're required to disclose to their audit committees whether or not we have any significant discussions with management about accounting-type matters. We did not this year, other than the remediation of prior year control deficiencies, which we'll talk about in a minute. And as in prior years, we've got great cooperation with management throughout the audit process, and we get all the information that we request for our audit, and management is forthcoming in providing that information to us. And then lastly, we ask management to sign what we call the representation letter, which is a long list of things that they represent to us that they're taking responsibility for, which includes the material presentation of the financial statements, that they are fair and accurate, which management did sign. So that's kind of the audit process. Outcome of an audit, a financial statement audit, is we issue the opinion on the financial statements. We do not issue an opinion on the internal controls of the organization, but we are required to understand those controls, and in some cases test those controls. And when we find weaknesses in those controls, we're required to disclose those to the audit committee and to the board of directors. We have to quantify or put those into 3 different categories. The lowest level is control deficiency, up to the most significant, which is material weakness. We did not have any material weaknesses this year. We did have a significant deficiency that we brought out relating to kind of the condition of the records, the accuracy of some of the reconciliations, and we're suggesting management go through a process to improve some of their month-end closing. So this is, again, it's not a material weakness. It is just something we wanted to point out that the condition of the records can be improved, although we did find the records in general to be in very good shape. It's not unusual to have a significant deficiency reported. The significant deficiency that we reported last year to you, primarily relating to information technology and the controls around that, were all remediated with the exception of one item which management is working on. We did not repeat that comment this year. So we're happy to see that the prior year items were remediated. So that's kind of the audit process. Before I just kind of cover a few things on their financial statements, questions on the process? Let me just talk a little bit about the financial statements. Again, these are management's financial statements. At the end of 2017, expenses exceeded revenue by $1,871,000 versus $1,158,000 the year before, and there are other changes in net assets besides the operating expenses exceeding revenues. There were adjustments to the pension liability, to the fair value of the swaps, and there are a number of contributions for capital that are down below that operating item. And when you put all of those together, we actually had a positive number of $7.4 million. And then if you included the restricted categories from the foundation, the total addition for the year was about $10 million. So the net assets, the fund balance, in some people's minds, or equity, in other people's discussion of balance sheet, increased by about $10 million this year. The calculation of earnings before interest, tax, depreciation, and amortization. So if you took that $1,871,000 that I talked about as being the loss for the year, and you added back depreciation, interest, and taxes, there'd be a positive $15,153,000 versus almost $14 million prior year. So this is a way of thinking of positive cash flow before we have to service our debt. Management also noted in the financial statements that there were 2 hurricanes that occurred in this fiscal year. Management determined that there was about $1,100,000 of additional expenses that were incurred as a direct result of the hurricanes, and disclosed that in the financial statement. There was also a certain amount of revenue that would have been lost during that period of time, particularly the second storm, that would have maybe showed up in October, but it would have been after the September 30th cutoff. Management made an estimate of that, but it's not disclosed in the financial statement. I think one of the other things to consider when you're looking at the statement of operations or the income statement for this organization is that we have a very high level of government payers. So it's almost 77% of the charges or the services that are being provided relate to Medicare and Medicaid. Those are known to be the lowest payers, generally speaking. So the opportunity to generate margin or profit from those payers is very, very difficult. And most organizations, and this is just a generalization, that number might be closer to the 50% level. The ability to pay the debt that the organization has, which is fairly minimal for an organization of this size, is if you took the numbers that I've already talked about and put that into cash flow relative to the amount of debt that you're paying, it means you have $2.90 to pay $1 of debt. So that's a pretty strong measure. And I think the real strength of this organization from operations standpoint, and it's really not operations, but it certainly makes this organization go, is a strong fundraising that you have. You've raised over $20 million in the last 2 years for certain capital projects, and I think that's to be commended for this organization. On the balance sheet side, the organization has 78 days of cash on hand. In other words, if everything stopped, you could pay all of the expenses that you have for another 78 days. This is just an accounting measure of strength on the balance sheet, just to give you some perspective.
That's consolidated?
That is consolidated.
Okay.
Now, that doesn't include the restricted cash in the foundation, though. So while it's consolidated, it excludes restricted cash.
Excludes restricted. Okay.
Mm-hmm. Days in accounts receivable at 46. This is fairly normal in the industry, somewhere between 40 to 50 days of receivables being uncollected. I mentioned earlier the low amount of debt that the organization has. Long-term debt to capital is 19%. If you looked at medians for hospitals of this size, that median would be somewhere in the 35 to 40%. So it indicates that the organization technically could put more debt on their balance sheet. And I also would mention that the debt that's on the balance sheet is being retired at a fairly quick pace. I think there's 10 years left on those notes, whereas a lot of organizations would have debt on their books for building projects of 20 to 30 years in length. So management determined that the capability was there to pay that debt back quickly and set it up that way. And I mentioned earlier the net assets actually did increase $10 million this year due to, again, contributions, adjustments to the pension liability, and the swap fair value. That's the end of my report. Any questions?
What is the level that the pensions are funded to? Do you know?
I think right now you're at, I wrote it down here because I knew that was important and I forgot. It's like 78%, George? 72?
Over 80?
Yeah,
82.
Okay.
In fact, correct me if I'm wrong, but I think the latest number we saw is that the pension fund is underfunded by about $14 million out of a total of 90 or something like that in terms of, is that about right?
Yeah, you're underfunded by $14 million at September 30th.
Yeah.
Mm-hmm. So general rule, though, I mean, the government, the PBGC will say if you're funded at an 80% level, you're in pretty good shape.
Yes,
right?
That is true.
Yeah. So
the current assets, the cash on hand, you said excluded restricted foundation assets, but if it excluded all the foundation, so that just the hospital, what would the cash on hand be then?
I believe that 82 is essentially the hospital's cash on hand.
No, you're talking about the pension. No, I'm talking about
Days on hand.
Days cash on
Yes,
hand.
the days cash on hand. I think that calculation is just the hospital's cash.
Oh, it is?
'Cause I think
78 days.
Foundation?
The days cash on hand includes the unrestricted from the foundation. You took that out, it's 1/3 foundation, 2/3 hospital.
Okay.
So you'd be in the 50s?
Yeah.
Yeah.
The total debt that the hospital now owes is in the neighborhood of $38 million. Is that approximately right?
It is 33,
33. Very good.
almost 34.
Okay. And do you know what the dollar value is of the undepreciated assets that have been given to the hospital by the foundation over the years?
I do not have that number. I think somebody had that number, maybe the foundation.
Your auditor has a much better sense of that because they've gone through and split them apart
Okay.
and looked at everything together.
Okay. Thank you. It sounds like a really great audit.
It went
result.
really well. It did.
So that's a good time to have a really good audit, actually.
Yes, it is.
Yes, it is. Any other questions?
I do have the full audit of the hospital available at the district office. I received it today as they were making the report. So if anybody wants to see the complete audit, I do have that at the office available.
Good.
Thank you.
Good.
Okay.
Okay.
All right. Thank you
Thank
very
you
much.
very much.
Thanks,
Yeah,
the
appreciate
opportunity.
it. George?
Good afternoon. How are you all doing?
Good. How are you doing, George?
I'm doing fantastic. I was here last year, as I recall, giving out the first quarter results at a $4 million loss, and I was a little nervous. This time I don't have nearly as bad. I have actually had good news to present, so I'm glad to be here. I handed out a summary sheet. I think you have them in front of you. Is that correct? And it's the year-to-date, 3 months ended December. I wanted to go through and talk about volumes and then staffing, revenue, expenses, and then net income. Just to get to the bottom line quickly, Indian River Medical Center for the first 3 months ended up with $560,000 of revenue over expenses. We had budgeted a $1.3 million loss, and last year we had a $4 million loss. So we're about almost $2 million better than budget and $4.6 million better than last year. Part of the uptick is related to volumes. We have a very significant volume coming through the hospital right now, and it continues in January and February as well. Our volumes compared to last year, for inpatient admissions, almost 3,800 admissions. We budgeted 3,500. That's about 9% more than what we budgeted for. And last year we had about 3,400, so it's about 13% more on the inpatient admissions. We've seen a decrease in observation. When I first got here, I talked about the predilection of the hospital to put patients in observation and the impact it had on that. We've worked with our clinical staff and our case management group to make sure that we have them in the right status going out the door. So we actually have less observations compared to last year and compared to budget by the tune of 15% compared to budget and 18% compared to last year. When you add both of the observation and admissions, which are people coming through the door, we're at 5,100. We budgeted 5,000, so we're about 2% higher than what we budgeted for and about 2.5% higher than what we had last year. Total patient days, which is our census, which includes the inpatient plus the observation, came in at 15.8 million. I'm sorry, thousand. What's a few zeros? We budgeted 14.6, so we're running 8.3% higher census than what we budgeted for, and a 16% higher census than what we had last year. Our emergency room is coming in close to what we thought we were. At 15,600, and we budgeted 15,200, so we're about 400 ED visits higher than what we budgeted for, and the same for last year, so that's about a 3% increase. Surgeries, we're actually doing very well on the surgery side. We had 2,000 surgeries. We budgeted 1,750, so we're about 14% higher than budget and about 15% higher than last year. And on our physician group practice, we came in at 68,700, which is about 3% higher than budget and about 8% higher than last year. Our staffing, or FTEs, while our volumes are up, our staffing is matching that. We do still, and it's in red if you'll see, we still have issues that we're working on to make sure that the non-clinical areas are at the right levels. But we are at 1,405 FTEs at the hospital and 334 FTEs for the physician practice, which puts us about 3 to 4% over budget and about 5% higher in the hospital to last year and 40% higher, 36% higher on the physician practice. We continue to acquire physicians. It's a strategy that's worked well. There is some startup costs that it's hard to deal with. As they come in, they don't hit the ground running with their revenues, so we still deal with that. But it's been a strategy that's worked well for us. On the revenue side for hospital, it came in at $56,200,000, which is we budgeted almost $53 million, so we're about $3,200,000 more than budget, or 6%. Last year we had $46.5 million, so we have a 20% increase of net revenue at the hospital over last year. On the physician practice side, we came in at $14.5 million, which is about 1% more than what we budgeted for and about 8% more than what we had last year. And again, that matches the doctor and the FTE piece I was talking to you about as well. VRA, we had some downtime related to the MRI. We've got a new one coming in. It's going to be loaded in and ready to go by about May. But the other one had to come down for maintenance, and there was some issues related to repairing it as well. And so we've seen a decrease on the diagnostic side. So our net revenue came in at $22.5 million, and it's 10% less than what we had budgeted for. Personnel cost came in at $41.7 million. Our budget was about $40 million, so we're running almost $2 million over budget, or 5%. Again, looking at the total revenue, though, and the volumes, most of that is related to that. Last year, we spent $38 million in personnel cost, which is about a 10% increase, an 11% increase. Supplies came in actually slightly over budget at $13.4 million. Our budget was $13.7, so we're 2% over. That's really related to the surgery volume coming through the door, and all other expenses came in at slightly under $14 million. We budgeted $14.4, so we're under budget by $500,000 in total. Income before depreciation is $4 million. Depreciation is 3.5. So EBITDA, which is the cash flow used to invest in capital of $4 million, again, you take out the depreciation, that brings us to the $560,000 of revenue over expenses. So it's a relatively good month, much better than last year, and continues through January and February as well. So who needs a partnership? No, I'm just kidding.
So
Any questions?
more sick people, or are you actually gaining some market share with something? I mean, where are you growing?
More people.
Well, I know more people are coming in, but I mean,
it's across the board. So you see it in the surgeries. On the people coming through the emergency room, more people are getting admitted as well. So that's emerging pieces. And I think it's just across the board. There is no one thing that's doing it. So.
Okay. All right.
Could I ask a question?
Sure.
You have more physicians that are joining IRMA. Are they coming from the community practices, or are they coming from elsewhere?
There were one or two that came from community practice. The rest we're recruiting and we're bringing them in to fill needs.
Okay.
Right.
Good. So new physicians coming into the
Yes,
area,
absolutely.
which is always very healthy.
Yes.
And then
Radiation oncology was a big one for us.
Which one?
Radiation oncology
Yes.
was a big one for us, and that doctor started about a month or so ago and is brought in quite a bit of work already.
Good. And the other question, you said that we're improving observation. We don't have as much now going into observation.
That's correct.
Okay. Are they being admitted, or are they being treated and sent out, and are you working with sort of a bridge program at all yet for the people that leave the ER to go home so they don't bounce back?
So one of our initiatives that we're working on now is making sure that we get them in the right status, but if they're either being discharged from the house or being discharged directly from the ED, we want to work with the community providers to see if there's opportunities. So whether it's rehab or home care or long-term care, or get them involved with their doctors, we're trying to do that as well. So.
Right. Just so they don't bounce back.
Correct.
Okay, very good. Those are my
bounce
questions.
back is not good. So.
I wonder if you'd comment about the recent announcement that we're now going to contract out the emergency room again, and I guess from a financial point of view, why that's being done and how that's being done, and if you've got.
So, do you want me to comment on the financial perspective of that, or the reason, or I'm not sure?
All of the above.
So
I don't know how far you want to go with this.
Okay.
But, I think the community is very interested in
sure
in seeing what the result is.
To run the emergency department, when we employed the physician, is not an inexpensive prospect. When you can bring in the right physicians and hire them, and have them employed, and have the rates that the national firms do, you do pretty well. You don't lose as much money. When we had the physician practice brought in, we had a very hard time hiring physicians, so we had to use locums. The locums cost about 50% more, or about $300,000 or $400,000 more per physician, and we had 50%, 40%, 60% locums that were bouncing all over the place, and it was a significant impact on us to be able to afford that. We came in and felt that with all that's going on with the partnership and our inability to bring in the physicians in to work at Vero Beach, it was better to have a national firm and use that firm to bring them in. So we've come to an agreement and signed an agreement that will cut the cost, the net deficit related to the ED practice, probably in half or a little more for the first year, and then much more after that as we settle things in going forward. Does that answer your question?
Yeah, I think it does. Though, are there any metrics in this arrangement that would relate to waiting times and service levels?
Absolutely. I think, and what they are exactly, I'm not sure. I know that our medical team worked with them to get them, but how long it takes to see a patient. I can tell you that Karen Davis, the new CEO, is really on top of what's happening in the ED. It's not just the ED physicians, and it's not just the ED itself. It's the other areas that impact it as well. Mm-hmm. So people are waiting because they may want to have lab tests done or diagnostics and things back up. And so she's on top of that and started a major initiative to kind of look at the process in the ED to see if there's opportunities to remove wait time and shorten a lot of things. One is to get the patient in the door and seen by a provider really quickly. So we're strongly considering having the triage process happen by a doctor as soon as they come in through the door, as opposed to going to registration and then sitting in the waiting room for that. And then there's other opportunities to make sure that when the doctors order something or they need some test done, that we have the right people in place to make sure it happens at the right time. So I think Karen has made this a high priority. I think the team that came in from Envision brings a different set of eyes and will also help us, because they say, that try it this way, try it that way. We've had 2 meetings already, and we're going to be having a weekly meeting going forward to try to iron this out. So I'm very hopeful, and I think there's opportunities to improve that.
I think they started February 1. Is that not correct, Envision?
That is correct.
February 1, and maybe we can have a quarter report next month on how they're doing, because I know they're hoping that this will really make a difference with how
And just to be
things
clear, a lot of the doctors that were employed by us are now employed by Envision.
So more continuity and more efficiency on
but
how
they're bringing
the docs stayed, is what you're saying.
Say that again?
A lot of the doctors
Yes,
stayed.
that's correct.
Okay.
And on top of that, they have 2 people down here managing the doctors and giving us these ideas too to help the process as well. So they're bringing.
I think they're quite popular with other hospitals as well. They have quite a
They have quite a few
national
hospitals in
presence
Florida, as a matter of fact.
ERs, right.
Any other questions for George? No?
Well, thank you all.
Right? It's so much better, isn't it?
Happy Valentine's Day. Missed you guys yesterday. Thanks.
Thank you, George.
Thank you, George.
Appreciate it. Funded agency report, Mental Health Association. Dr. Brignoli,
Good evening.
welcome.
So I'm going to just run through the report that I had provided. Starting out with our entire, agency in terms of our walk-in center and the services that we provide there. For October through December, we served an unduplicated count a bit higher than our usual quarter of 532 unduplicated clients. Our annualized figure, if you're wondering about that, is about 1,000 that we see over the course of a year. And, if you look at this data, I provided a year of data. There, it's pretty steady across the board until we get to like our psychoeducational classes and psychoeducational group therapy, where we are trying to do some things a little bit differently. We're doing more classes than what we're calling therapy in the hopes that we'd get some folks coming in who wouldn't necessarily be reluctant to do that because of mental health stigma. So we're doing mindfulness classes now instead of calling it a mindfulness group. And we're carrying that across the board in some other areas. If you remember, I think a couple of reports ago, I talked about some of our psychoeducational groups that we were starting. We went through one cycle of those. Those groups were about 10 to 12, and we started those up again. There was a period of a couple of months where we weren't running those groups, and we're starting them up again in January. So that accounts for some of the fluctuation here. The other thing I'll report is that, as I've reported in the past, we do have some peer support recovery specialists working in our drop-in center, which you do also partly fund, working with mental health court clients who come to that center. And you can see the amount of sessions or services that they're providing to those clients is increasing. We think that number will continue to increase. We also think that those two part-time positions may actually grow into perhaps a full-time and a part-time position. There's a lot of need there. And some of those sessions take place at the drop-in center, and on occasion our support specialists go into the home to do those. That's very time-intensive to drive to and from places, so we really hope that they can make it to the center because they can avail themselves of, our drop-in center. They can avail themselves to everything else that goes on there. The next set of numbers have to do with hospital district clients only. So you can see that over the quarter we served 111 unduplicated clients. Again, that's pretty steady. However, if you look at January to March, it was 97. And then you can see the various numbers for screenings, diagnostic assessments, psychotherapy across the board. I do want to point out that the psychiatry row of 102 in January to March to 100 medication management visits in October to December, that's for the University of Florida psychiatrist who's in our facility. And, we aren't reimbursed for those services, but we do provide a place for those, for their psychiatrists to see individuals. And it's actually better that they see them at our place because we have a medication assistance program and we can help them two ways. Once with the pharmacy dollars that we get, from the district, but also for many of their medications also get them directly from pharmaceutical companies to reduce the cost of medications to the district and to the clients that they have to pay. Not much else to say about that. When we get to the financial data, though, I do have more to report. I mean, roughly here you can see some uptick in the number of services and clients that we're providing services to, and I think that's reflected in some of the financial data. The next section of the report looks at our clinical outcome measures for October through December. These numbers look a lot like the numbers that I provide, pretty much every quarter. In terms of our favorable discharge criteria, which has to do with people who completed their treatment plans by discharge or met what we define as maximum medical improvement. We also include some successful transfers because there are folks who were doing well in therapy and they moved out of town or got a different insurance. That number was 71%. We run about 69, 70%. That benchmark of 70% really kind of comes from the psychotherapy literature, since a lot of what we do is psychotherapy. And if you look at the outcome of psychotherapy, the number that the American Psychological Association still puts forward is that about 75% of people who get psychotherapy show some improvement. So our standard's a little bit higher. We've reduced it down to 70. So we feel we're doing a pretty good job, at least in comparison to what the literature says your numbers should look like. Then the next three measures have to do with what the PHQ-9, which is a measure of depression, a self-report. So the client rates themselves when they first come in on their symptoms, and then we have them rate all along, but also we have a final rating. And then we have the GAD-7, which is a rating of anxiety that they also take beginning and end. The second outcome has to do with the number of people who showed improvement on one or the other by discharge. So that figure was 88%. Then we look at the number who showed improvement either just on depression or anxiety, and you see that 84% showed a significant drop in depression, and then only 69% on anxiety. We've asked ourselves why the anxiety numbers, why are they less than the depression numbers? A lot of our clients who come in to see us are either receiving anti-anxiety medications, from primary care physicians or somewhere else. So we're fighting a losing battle there. They're already receiving, a medication when they get to us that's already reducing that to some extent. And some of the clients we've seen have been on benzodiazepines for many years, which means they're no longer getting increases in those medications, and they're actually suffering some form of mild withdrawal throughout the day, trying to be maintained on that amount. So despite our efforts to teach, various forms of meditation and to help with other, thought restructuring and reframing techniques to help people who are excessive worriers, we don't see the kind of improvements there that we see in some other areas. The other thing that we manage, since we do a lot of mental health screening, we do actively attempt to follow up with everyone who we see. The benchmark that we use, frankly, people aren't telling us that family members aren't telling us that people are suiciding. We are not being told that the people who we see have been at risk, significant risk. The benchmark, though, is, in terms of what the literature tells us we can predict, if we screen them and they, were safe for a 48-hour period of time, then we feel pretty good about our prediction. Obviously, if they leave our facility and later on that night end up, admitted to the hospital or Baker acted, that's not a good sign. So we feel we've always done very well in that area. We have very careful danger to others and danger to self risk assessments that are mandatory under certain conditions, and they get very careful supervision by our clinical director, Jeannie Shepard, on those tools. We also do client satisfaction survey results once a week. Anyone who comes into our clinic, we have a random day of the week because some clients only come in on Thursdays, so we want to get every day. Anyone who comes in to our place is asked to anonymously complete a satisfaction survey. It's voluntary, though. We don't force them to. And so here you have the data for October through December. And again, this data looks a lot like our data generally looks. The first outcome, though, is 67% of clients reported strongly agreeing or agreeing that they felt less stressed after their screening. So those are people who come in for that first time. That number is usually in the low 70s. We're going to watch that number. We don't want that to go down. It's obvious, though, in a one-shot deal and you have, an hour to an hour and a half with a client, if they're highly stressed when they come in, on occasion they're, and in this case, 33% of the time they're not reporting that. But if you look at our data in terms of feeling more hopeful after that screening, it's 79% of clients agree or strongly agree. Then at number 3, 88% after a therapy session, when they come in. Actually, we say therapy, but we also, same thing with psychiatry visits. If someone comes in for a psychiatry visit, I really do need to change that. 88% agree or strongly agree they felt less stressed after that visit. The hopeful figure for people who are in ongoing treatment is 84%. And real telling data, the fifth one here is whether someone agrees or strongly agrees that their treatment needs are being met at the MHA, and we've never seen a figure like this. It was 97%. So we really feel that, the people who are coming to our place are making progress, and they do feel that the treatment that we're providing, for the by and large, is meeting their needs. If we then move on to some of our drop-in center data, we provide you with the statistics for all 3 of our drop-in centers in all 3 counties. Of course, you fund our drop-in center in Indian River County. If you look at the unduplicated count, that keeps going up. It's up to 160 for October through December. The visits were at 2,700. They're somewhat down from January to June. They're generally down in July through September, but one of the things to point out is from October to December, because of the hurricane, that we're open every day, and it was literally closed for like 7 days, and our clients have a harder time getting around. So I think in part we're going to see a pretty substantial increase, I think, January through March. So I'll be able to see if my prediction is accurate or not. We also do client satisfaction data. The way that we report it here, it's kind of odd, but this is a state requirement that we do it in a certain way. But what you see is, what we have to do is collect data during a particular week of every quarter. This data was collected from November 12th to the 18th of 2017. And again, the clients are offered, it's voluntary, but anyone who comes in that week is offered to do one of these satisfaction surveys. And you see, by and large, the people who go to that Vero Drop-In Center, they really feel that it's a very welcoming place, that it's a place where they can be accepted by other people with similar kinds of problems. They have access to the various support groups, and we have a computer lab there, and musical instruments. There are people who just go there to play music. We actually have that in a air-conditioned garage, so it truly is a garage band. And there are various arts and crafts and other things that do go on there. I have to tell you, it's really interesting. We have all of the professionals at the walk-in center, but when I need to relax, I go to the drop-in center on my way home and spend a few hours there in the afternoon.
That might be a good idea for all of us.
Actually, you might. I mean, it really is a very, very positive place, and we have more and more mental health court clients there, and the place really isn't changing. Most of these folks are folks who got goofy in the community and got arrested, or stole a candy bar. It's unfortunately. Mental health clients do tend to get arrested when they act out in public. So, and when they commit, minor crimes, obviously there's a great opportunity for them to not have a record. So that hasn't really changed the feel of the place, and many people still go there for meals and special events, and we take them out into the community and all that stuff. But it's pretty serious. The people who are there have chronic and persistent mental illness. They're coming there. They're having suicidal thoughts. We are collecting data on arrests and those kinds of things. The arrest data is skewed now because people are consciously coming there who are going to say that, yes, I've been arrested because they've been sent there. People who go there do end up hospitalized. I've mentioned this in the past. Most of the clients who go to our drop-in center who are severe and persistent mentally ill aren't necessarily our clients. We don't see a lot of them at our walk-in and counseling center. Most of them are New Horizons clients. And that's really a good thing because New Horizons case managers can kind of pop in and say hello. We do actually do some parties with New Horizons case managers, for various events where their case managers will come and do an ice cream social or something like that at times. So we feel what we do at the drop-in center is very valuable. It kind of brings us to our financial data. And our cash position as of December 31st, our checking account is lower than usual, and part of that has to do with our profit loss statement that's below this. Our money market, we haven't touched it. It just grows a little bit, with interest. Our endowment fund we had some substantial increases last month. And by the way, we did get our audit. It's a clean audit, and we'll report on that next quarter. And if you'd like a copy of it, I can send it to you as well, to Anne-Marie. So for the 3 months ending December 31st, you can see that we have a net loss of close to $40,000. Now, just based on how our budget runs, we receive hardly any grant money. So we actually expected that number to be closer to $20,000 than to $40,000. The $20,000 that concerns us is partly a decrease in program fees that we take in. Program fees, we call them program fees, but it's folks who pay us on a sliding fee schedule, and it's any insurance reimbursement that we get. And we do have a few people who come in and want to see a particular therapist who will pay whatever. They'll pay, they have the means and they pay the fee. That accounts for about half of that $20,000. The other $20,000 has to do with our contributions and donations, and we're kind of timing our annual fund a little bit differently, but we're concerned about the $20,000, and I'll tell you we're concerned about the $40,000, but I'll tell you some of the things that we're doing as a result of that. The program fees are down because reimbursement levels, particularly with Blue Cross Blue Shield, are going down. As of October 1, one of the changes that they made is they decided there's a psychotherapy code. It's called the 90837 code. They decided that you can continue to use that code if you spend that number of minutes with a client, but we're only going to pay you at the 90834 level, which happens to be about $30 lower per event. So just to give you some perspective on this, if you now look at that, and I don't want to take up a whole lot of your time, but I was one of the first psychologists to be a preferred provider for Blue Cross Blue Shield. It was about 1987, and the reimbursement rate for psychologists at that time was $70. And with this $30 decrease, guess what the reimbursement rate is now for psychologists? $70. So, to me, this is criminal, but, I'll get off my soapbox. We have some challenges there. One of the ways that we're attempting to meet it, because we really don't want to risk it by hiring more people to see more people to make up for this. Our clinical director, Jeannie Shepard, is going up from about 33% direct service to 50% direct service. I do about 10 to 12 hours of direct service a week. I'm taking clients again, so I'll see some more people too. And we're also looking at things like our no-show rates, our cancel same days, although I think I reported on that last year. We really put a dent in that. That really is significantly improved. So I hope we have a much better number in the profit loss area. In terms of the hospital district revenue, we're above budget. I don't know, Anne-Marie, if you've kind of noticed that, but I think we're billing about if you look at it, if it's going to be steady every month, I think we're billing about $3,000 over. Now you might ask why that is. My best, because we've been going down. My best explanation for that is now that folks who are qualified for funding, they can just walk into our place now. And we have people who are walking in who are qualified in other places, availing themselves of our services. But we're going to watch this, obviously, because we have always, asked for less, ended up collecting less than we asked for. But these numbers are off a bit, and we are aware of that. Lastly, I just want to report that we are proud that we did get the United Way Agency Excellence Award for 2017, so we were real pleased to get that.
Congratulations.
Thank you. Any questions?
I have two. Michael, did you have a question?
I have a question.
Go ahead.
When you talk about arrests, what relationship do you have with the sheriff when it comes to people who are incarcerated? Do you see them or they get treated by the sheriff? How do you do that?
Okay, in terms of, I believe that the sheriff puts out has a contract for people to see those folks.
New Horizons?
And that's traditionally been with New Horizons. I didn't know if it was still with New Horizons. For a period of time, and we're just not being asked to do it any longer, because they might have solved the problem. They had some individuals who were incarcerated, and the period of time between their release and actually getting their appointment to see a psychiatrist in the community was too long. So what we were doing is we were doing some stopgap sessions, where they could come to us, and we would have, our psychiatrist see the person to just kind of bridge that gap. Our relationship with the sheriff's department now is, there are times when we screen somebody and they need, our clinician has to Baker Act them, and they're very gentle with clients. They know our facility. They come in the back way. We feel like we have a really good, working relationship with the sheriff's department. We rely on the police department and sheriff's department all the time to do wellness checks on our clients that we're concerned about. Occasionally someone our therapist is concerned about misses an appointment. We have a requirement that client gets a phone call that day or within 24 hours to find out, why they no-showed for their appointment. And if we don't hear back from them and anything unusual is going on, we ask law enforcement to do a wellness check.
Thank you.
Okay, my question. We've all been shocked by what happened down in Parkland yesterday.
Yeah, absolutely.
And I do assume that any teenagers or any children that exhibit behavior that shows a mental health problem, that they would be referred to a psychologist or a psychiatrist. But are you all are you doing anything in the schools for education of the school children about recognizing aberrant behavior and how that can be reported, or to avoid things like happen? Because apparently this child did act out quite a bit. He was expelled from one school, but what do we do to protect our children? And what's the education going on in our schools?
Yeah, that is a great question. When I took over the MHA, what the MHA's mission is always to do is to fill gaps. So one of the things we weren't going to do was to go into schools to provide services. There are plenty of agencies who are already doing that. Suncoast does that. New Horizons does that. Sequel Care does that.
But they have to go to them, or do they go into the schools?
They go into the school.
Okay.
Yes,
okay.
They do.
Okay.
There are mental health services that are provided in the school. Okay. So our tactic was more to figure out, well, how about those students who aren't being seen in the school? So we got ourselves into Gifford Pediatric Health Center, so we caught a different population there. And actually, because we're a walk-in center, actually now a number of resource officers know about us, and we actually do get, a guidance counselors calling our walk-in center, sending a parent with a student who posted something strange on Facebook. And we've actually had resource officers on 2 occasions bring the student to us, and the parent met them there. So we're always available to see, anybody free of charge. Now, in terms of doing stuff in the school, I think there is a place that we could fill. One of the things we're wanting to do as an agency is to move more into prevention and wellness. So we're going to start offering some classes to the community, more on the adult level, and for seniors. I wrote a grant. We're now going to be doing some stuff at the Boys and Girls Club beginning in April in the after-school program, where we're going to be doing some things there. And I did write a grant to hope we get the money, where we're going to do some training for parents on resiliency and do some social skills training with kids as well. But, I think that there's a lot that can be done, in this particular arena. The problem is, but here's one of the problems, my PhD is both in clinical psych and school psych. I spent a considerable amount of my time in schools. There are many, many, many troubled children in schools. It shouldn't be a surprise to anyone. I think the statistic now is 20% of our children have significant mental health needs, and only about 50% are getting any help for it. And, the lifetime statistic is in somebody's lifetime, 50% of people have a diagnosable condition. So it's important that we identify kids in need of mental health care, but that's a lot of kids. We got to figure out, how do we identify kids who need mental health care, who also happen to have anger management problems and a history of violence? Because those are truly the kids who we need to be intervening with. Kids with histories of cruelty to animals, kids with large conduct and discipline problems in the school system. So it's really, we need to look for that subset, kids with mental health issues who also have these anger issues and already have violence issues. And from what I've read about this particular student, I haven't had a whole lot of time to read a whole lot.
Right.
There were lots of signs that he was, that there were anger and weirdness issues,
But a lot of these children become isolated, and then others sort of leave them alone and isolate them even more. So there's so much education, I think, that could go on in our schools.
Yeah, absolutely. Most school systems, and I haven't looked to see what's going on here, but they all do have teams to keep safer schools. So they're already doing some stuff, and if we're going to do some stuff, obviously I want to see what's
being done here
done.
in Indian River County. But I mean, it's like it can happen anywhere.
Yeah, it's time. I mean, I can't believe it. What the statistic is, since the first of the year, there've been 12 school shootings that I hear, or something like that. That's crazy. Terrible. That's just crazy.
And also, my second question: how are you doing with your fundraising? Are you keeping up with the times?
Well, we have an event coming up in March. We're hoping that is a successful event, and we'll see. We're launching our annual fund campaign a little bit later this year. Right. And, since I got there, we seem to bring in almost exactly the same amount of money in donations and contributions every year. So we hope this isn't a downtick year, and we hope this can be an uptick year. There are a lot of people out there.
There are a lot of organizations.
There are a lot of organizations that are out there.
Yeah.
We like to think that the special things about us is our walk-in center, and also, some of our commitment to children and veterans. So those are the things that we think make us a special place in need of funding.
So if we could help you help the community in any way, what would that be?
Oh, you mean in addition to something new that we could do? Oh, if there was something new that you wanted to do, with my background in terms of working with the schools. I mean, I did all the Safer Schools, I've done all kinds of training when I was involved with the St. Lucie County School Board. Let me go and talk to the powers that may be at the school and see. I don't want to duplicate anything, but if there's something that we can do, something that I know about that's evidence-based or promising and something that they don't have the means to do, I'll come back off the top of my head, whatever we do.
Prevention.
Yes, in the prevention and early emerging, right? We want to catch the early emerging and
avoid
problems
a tragedy.
and do some prevention.
Right.
Yeah, those are the two things we want to do.
Come back.
Okay.
Thank you.
Very good. I will do that.
Thank you.
Yeah.
Thank you for your time.
Thank you.
Any unfinished business? Any new business?
I just want to report that we had a very good WeCare meeting at the district office on February 6th. It was very well attended, and we will be forthcoming with some report on the WeCare program.
Thank you.
Good. Any other business? Any public comment? Hearing none. Hear a motion for adjournment?
So moved.
Second?
Where's Val?
All right. Let's go. Thank you very much.